Bismillahirrahmanirrahim. Today we will have case quiz number 37. Case data: 73 years old male with diabetes mellitus, hypertension, and coronary artery disease, presented with fever, weakness, and dry cough lasting for 1 week. Also his wife had similar symptoms for 3 days. On examination, temperature was within normal, heart rate within normal, blood pressure 100/70 within normal, respiratory rate slightly increased 22 breaths per minute, and oxygen saturation 96%. Laboratory investigation show white BCs within normal, neutrophil within normal, lymphocytes within normal, and platelet also within normal. AST slightly elevated, ALT slightly elevated, creatinine within normal, CRP negative, D-dimer within normal. Nasopharyngeal and oropharyngeal swabs were negative for COVID-19. Chest computed tomography showed bilateral peripherally located ground glass opacities at the upper and lower lobes. The patient was diagnosed as suspected COVID, although the negative swab, and received ceftriaxone, hydroxychloroquine, and azithromycin. His cough, fever, and fatigue were improved gradually. He completed the 5-day course of hydroxychloroquine and azithromycin and 7-day course of ceftriaxone. 8 days after completion of treatment, swelling, redness, pain, and tenderness in the left first metatarsophalangeal, proximal, and distal interphalangeal joints were developed of the left foot, followed by 2 days later with similar finding in the right second proximal and distal interphalangeal foot joints. At the same time, the patient had markedly elevated CRP, ferritin, and D-dimer levels. Radiological examination of the affected joint revealed normal findings. Venous and arterial Doppler ultrasound imaging of bilateral lower extremities show no pathological signs. The screening laboratory tests for arthritis were unremarkable. Rheumatoid factor was negative, anti-CCP was negative, and uric acid level was within normal range. And finally, the patient responded well to non-steroidal anti-inflammatory drugs. So, what is the diagnosis? I think the case is very easy. It is, yes, it is post-COVID-19 reactive arthritis. To our knowledge, this was the first reactive arthritis case caused by COVID-19 reported in Turkey in late 2020. Reactive arthritis belongs to a group of diseases known as spondyloarthritis in a sterile joint. Inflammation triggered by a distant infection in susceptible hosts. The time required for the development of reactive arthritis after infection takes few days to 4 weeks. Reactive arthritis is characterized with typically asymmetric monoarthritis or oligoarthritis, mainly of the lower extremities as seen in our patient. Although classical reactive arthritis is associated with urogenital and gastrointestinal infections, non-classical reactive arthritis can be triggered by most other infections, including upper and lower respiratory tract infections. Because of the atypical pattern of clinical presentation of arthritis plus the evidence of COVID-19 by CT and clinical picture, the patient was diagnosed with reactive arthritis caused by COVID-19, and this, as I said before, this was the first recorded case of reactive arthritis post-COVID uh, during the current pandemic. Gastrointestinal system may serve as a secondary site for COVID-19 infection in relation to the expression of angiotensin-converting enzyme 2 in the gastrointestinal tract. Reactive arthritis may be related to this involvement. COVID-19 is not a disease that is fully understood yet. In the course of time, clinicians all over the world experienced several different forms of COVID-19, and today the term COVID-19 or post-COVID-19 syndromes is rapidly rising. And finally, thank you very much for your attendance, and see you tomorrow with case quiz number 38. Wassalamu alaikum wa rahmatullahi wa barakatuh.